When we think about how we treat patients with atrial fibrillation, there's really three approaches we take, and all of these are important. Approach number one is rate controlled, because we're controlling the fast rate. And there are medications we use to slow down how fast the heart is going during atrial fibrillation. The second approach is called rhythm control, and when you have a fast irregular heartbeat caused by atrial fibrillation, if you make the atrial fibrillation go away, then of course the heartbeat goes back to normal. It's now no longer rapid and irregular. That rhythm control approach, it means exactly what it says, we're controlling the irregular rhythm, involves using medications most often to get the heartbeat back to normal, occasionally using a procedure called cardioversion, which is the paddles that people have seen on ER and other TV shows. You put paddles on the chest, you put the patient to sleep, and you give them a small electrical shock, which is very safe and very effective at getting the heartbeat back to normal. Or in some cases, we consider a procedure called radiofrequency ablation, which is a more invasive procedure where we put tubes inside the heart, find all the short circuits that cause the atrial fibrillation, and zap them. And hopefully that will prevent recurrence of the atrial fibrillation. That's something that is not done in all hospitals. It's a pretty complicated surgical type procedure, and it's applicable to some but not all patients. It's quite different in terms of the approach. Number three is the idea here is to prevent the most serious consequence of atrial fibrillation, apart from feeling unwell, and that is the risk of stroke. All doctors who see patients with atrial fibrillation and all patients who have atrial fibrillation need to be aware that this is a potential risk. The way to deal with this is to use medications to prevent clots from forming or from traveling up to the brain. And these are so-called blood thinners. The technical term is anticoagulants. Now, different patients require different kinds of anticoagulants depending on their individual risk of stroke. But the idea is that for all patients, we should be thinking about that. Patients should be thinking about that. And the doctor needs to have a conversation with the patient about what blood thinner is right for you and how should we administer it. The purpose of medications is not necessarily to get rid of the entire problem. It's often not possible to prevent all of the episodes, and patients need to understand that it may not be realistic that we totally fix the problem. What I say to patients is, if we can reduce your number of attacks or the severity of your attacks to some acceptable level, is that okay for you? And most patients say, well, it's not ideal, but that's okay for me. We don't tell patients we're going to get rid of the whole problem. That's not realistic. We want them to feel better enough that it's now an acceptable quality of life.